first question, the options are very important. You have to actually know the concept of each of the option. You don't, even if you got the answer right, it's not a big issue, but you have to kind of focus on the discussion here. So here the answer is option 1, because it's not an autoimmune disease of the fetus directly, and there are two wrong statements here. One is that the autoimmune disease of the fetus is not exactly a correct statement. Secondly, active acquired autoimmunity. This is definitely wrong because it is a passive acquired autoimmunity. So what happens in this disease is the maternal antibodies transfer transplacentally into the fetal body, and there these antibodies, mainly the anti-Ro and anti-La antibodies, kind of act on various organs of the neonate and cause autoimmunity. So this is autoimmunity, yeah, but it is a passive autoimmunity, passively acquired autoimmunity. It's definitely not right to call it as an autoimmune disease of the fetus. The next three options are something that you should remember. Firstly, betamethasone, dexamethasone are two excellent drugs which are used to prevent the occurrence or progression of fetal congenital heart anomalies, that is mainly the fetal heart blocks that are there. And you have to remember that why we are using the betamethasone or dexamethasone. So usually what we treat the mother with is the prednisolone, the usual steroid, but that is not able to cross the placenta. So what we do is we use fluorinated corticosteroids that are able to transplacentarily go into the fetus as well. So that is the reason why we use dexamethasone or betamethasone that can transfer into the fetus and treat the fetal condition as well. Next is the typical rash. So typical rash is, this is how the typical rash looks. It's usually periorbital in distribution, not usually involving the central areas of the face, and the scalp is rarely involved. Mainly the periorbital area is involved. Here you can see central face involvement, but it's usually not common. And also another very important thing is that it disappears by around 3 to 4 months. So it appears by around 6 to 8 weeks and disappears by around 3 to 4 months. Then you have the fourth option, that is a very important concept to know as such. That is whenever you have women or mothers with anti-Ro, anti-La antibodies. So these are the harbingers or the main antibodies involved with neonatal lupus erythematosus. So women or mothers with circulating anti-Ro, anti-La antibodies are monitored by screening echo from at least 18 weeks up to 24 weeks according to some recommendations, 26 weeks according to some. So at least 8 weeks across that time you have to do 8 echoes, that is weekly echoes have to be done from at least 18 to 26 weeks. And there are some recommendations that suggest that you can also do a bi-weekly echo up to 34 weeks as well. Obviously you will do T2 scan after your 20 to 26 weeks, but after that at least what we follow is we recommend weekly scanning up to from 18 to 26 weeks, and then at least 2 more scans up to 34 weeks. So again, as we see various all the other options here, explaining them, neonatal lupus is due to passive transfer of maternal autoantibodies, mainly anti-Ro, anti-La, that transfers across the placenta, and it is thus not an autoimmune disease of the fetus, but a result of maternal autoimmunity affecting the fetus. Then you have these fluorinated corticosteroids which are used especially for pregnant women to reduce the risk of neonatal lupus erythematosus. Annular rash, as already described, affects the periorbital area typically and disappears by 3 to 4 months. All pregnant women with anti-Ro, anti-La antibodies specifically should undergo weekly screening from 16 to 26 weeks and bi-weekly up to 34 weeks. So coming to the next question, this is a question that was asked in the recent INISS. It was asked in the general pediatrics. I initially had felt that this was asked as a pediatric rheumatology specialty question, but this was seen in almost all the super specialty papers. So I did confirm this with the consultants that are there. So the answer here would be A. So I'll come to why the A is the best option. This is in fact quite a twisted question with 2 or more options you can get confused upon. So forgive me for the typo here. It's a 5-year-old boy presenting with a history of recurrent attacks of secretory otitis media or serous otitis media along with purulent nasal discharge, and it was revealed that Haemophilus influenza is growing in the ear discharge. And the most important finding here is that there are no tonsillar tissue and no palpable lymph nodes. So you usually expect lymph nodes, lymphadenopathy to occur, especially in small children, and especially when there is a sinister infection like Haemophilus influenza to be there. But here you don't see any tonsillar tissue. In fact, even You don't see in the sense the patient might have undergone a laryngoscopy or a pharyngoscopy, and there no tonsillar tissue might be seen and no palpable lymph nodes were there. So before we go to how a PID is approached, PID is now called an inborn error of immunity, but however you can get the flow, that is the same thing. So PID is approached either for children or for adults. It's approached in the same manner, that is, in the sense the warning signs considered are very similar. To be told broadly, it mainly includes more frequency of infections, more severity of infections, weird locations of infections, more resistance to treatment, and obviously possibility of normal commensal organisms transforming into pathogenic strains. So here you see that 4 or more new ear infections in the last 1 year. So these are how the requirement or a warning signs of PID are to be seen. So 4 or more new ear infections, 2 or more new serious sinus infections in the last year, 2 or more pneumonias, failure to gain weight. So this is very important to be seen. Whenever you get a referral, for example, that this child may have a primary immunodeficiency, you have to ask for 2 very important things apart from obviously your infection history. That is the failure to gain weight or the failure to thrive, and the second thing is family history. Then you go into depths, that is how frequent the infections were, how severe the infections were, if they were recurrent, deep, kind of abscesses, if they were persistent infections. Suppose any child having thrush or fungal infection usually responds to antifungals, usually even kind of copes on his or her own, but here there will be persistence of that infection. The IV antibiotic requirement for a simple pneumonia will be very refractory, and it takes a lot of time to clear these infections, and also they are deep seated. When it comes to adults also, which this kind of is important in the context of maybe adolescents like 15 years of age, you have to have a slightly lower threshold. That is, even if 2 or more new ear infections in the 1 year, 2 or more new sinus infections, the absence of allergy, 1 pneumonia per year for more than 1 year, chronic diarrhea, and obviously the other things that are recurrent viral infections, fungal infections, severe infections, family history, etc. All of these are warning signs. Then you have these 4 stages of testing. So this is where our question lies. So initially you will do a basic history physical examination and your complete basic evaluation, which includes CBC and differential count. So this again, CBC and differential count is to be said not just for the sake of it. You have to see how your WBC counts are, how your neutrophilic counts are, how your lymphocytic counts are here in the differential. And then along with this, you also have to see your globulin levels. So we know that in normal biochemistry panel, we do our total protein and albumin levels. In that also, you can do the total protein minus albumin to get a measure of your total globulin levels, and you can compare that as well. Then along with that, the most important part is the first step itself includes immunoglobulin levels. So first stage of testing itself includes immunoglobulin levels. But if you see our question, there are 2 options with immunoglobulin levels. That is one reason why you cannot mark both of, either you have to mark either both, which is obviously not possible in a single answer exam, or you have to look for a exact option fitting into it. For example, if this was a IgA deficiency case, but the thing is IgA deficiency does not present like this. It does, patients do have palpable lymph nodes, do respond with tonsillitis, etc. So here IgA concentration alone obviously would not suffice. IgG and IgM concentration alone again would not suffice. So either you have an option with the complete Ig profile, or what it was supposedly being tested here was, if you know that flow cytometry is done as a frontline test in PID analysis, and that is where this particular test comes, that is lymphocyte surface markers are tested with various CD markers with the help of flow cytometry. Now I don't really agree with how correct this particular answer is, but that was what I could gather from essentially the ones who were setting this question. So I would suspect that maybe you can go with this option D. If somebody is going with this D option, I would not kind of say the line of process is wrong at all. It's a very good option to mark, but essentially the answer here was measurement of flow cytometry, because the immunoglobulin levels has to be tested as a whole, as a panel, not just as Ig levels or IgM levels, etc. It has to be done, the profile has to be done with IgG, A, M and E levels. So other stages of testing involve lymphocyte proliferation testing, oxidation burst, if there is phagocytic defects being tested for, response to pneumococcal vaccine. So as you can see here, these antibodies to antigens of routine immunizations have to be tested to just check whether the active immunity is working. Then gene sequencing obviously exists. Then you have the stage 4 testing, which include whole exome sequencing and all of these tests where you kind of test for phagocytosis, and slightly lesser common kind of immunodeficiencies like complement assays are done to look for complement deficiencies, various NK cytotoxicity studies are done, etc. So this is why the answer here was best to be flow cytometry, because that actually is a proper test that at least tests for all the lymphocyte surface markers. If you look at only IgG, IgM, it might not tell you the complete picture. So the diagnosis should be suspected if lymphoid hypoplasia, as I already told you, that is a very important marker of something like an A-gamma globulinemia or a hypogamma globulinemia. X-linked A-gamma globulinemia may be a very good differential here, but it can be present in severe hypogamma globulинemias in various other PIDs as well. So minimal or no tonsillar tissue and no palpable lymph nodes. When you look at the prevalence, obviously XLA or Bruton's A-gamma globulinemia will be the first differential. And then flow cytometry is used to demonstrate the absence of circulating B cells. The flow surface markers are checked, which will distinguish this disorder from CVID. And also next you see other options where IgA deficiency, although it is common, it is among the most common, but you will definitely see kind of lymph nodes and tonsillitis here. And also measuring Ig alone might not be sufficient in these cases. Measurement of isohemagglutinin titers, which are antibodies against the surface of RBCs, which are usually seen in the childhood when there is exposure to maternal antigens, is useful in assessing immune response to blood transfusions or certain autoimmune conditions in general, but definitely not relevant for evaluating PIDs like XLA. Then you have IgG and IgM concentration, which are not completely, doesn't provide the complete info. Then also you have measurement of antibodies to antigens of routine immunization. This is an add-on test, but it is not definitely a first-line screening test. Now we have the third question, which is a very interesting question because this question is repeatedly asked in your IAP quizzes. For some reason, this is the most favorite topic in your IAP quiz. That is complement deficiencies associated with various clinical manifestations and physiological consequences. So C3 deficiency or factor I deficiency basically leads to an inability to generate C3b and eventually leads to a failure to generate MAC or the membrane attack complex. And here mainly encapsulated bacterial infections like Streptococcus pneumonia is there, Haemophilus influenza and Neisseria meningitidis are mainly highly suspected here. Then you have early complement deficiencies like C1q deficiency, C2, C4, etc., where SLE is a prominent disease associated. Then you have factor D or propyridine, where mainly Neisserial infections are associated here. Then you have factor H or factor I, where the thrombotic microangiopathy, that is hemolytic uremic syndrome, is associated. And also you have MPGN or membranoproliferative glomerulonephritis. Then you have C1 inhibitor deficiencies or C1 esterase inhibitor deficiency, which we will come to a little bit in detail in the upcoming questions. And this leads to angioedema or hereditary angioedema. Then you have CD59, or it's also called decay accelerating factor, which is associated with paroxysmal nocturnal hemoglobinuria. So here in this, obviously you have early complement defects associated with SLE, C1 esterase inhibitor deficiency associated with hereditary angioedema, and factor H deficiency associated with atypical HUS. And the option answer here is discoid lupus erythematosus. So you have to understand that DLE or discoid lupus erythematosus is not a subcomponent of SLE. That is why this option I had put forth here, because DLE many times is considered kind of that in SLE there is DLE, but it's not exactly like that. DLE on its own stands a good cutaneous, it's a nosological entity, which is basically a cutaneous disease in itself. So that itself without SLE can also exist, and that is why DLE is definitely not the correct answer here. So C4 deficiency leads to an impaired immunocomplex clearance, which leads to an increased autoantibody production, immune dysregulation, eventually leading to SLE. So this is how it happens, that early complement deficiencies in general lead to a poor immune complex clearance, leading to generation of anti-nuclear antigens, anti-nuclear antibodies, leading to SLE. So apart from that, C1 esterase inhibitor, we will come to how it leads to hereditary angioedema. Factor H defect associated with atypical HUS, a condition characterized by MAHA, TTP, not TTP as such, thrombocytopenia, and also acute kidney injury. Next, we have another question mainly focused upon hereditary angioedema. So hereditary angioedema, angioedema in general is basically a swelling of your subcutaneous blood vessels leading to swelling of your subdermal tissue because of your extravasation of fluid. So this is a case where a 11-year-old girl presented with sudden onset swelling of lips and the tongue, and similar swelling was also seen on the face 2 months ago, which resolved spontaneously, and also there is no history of any prominent trigger like insect bite or recent trauma or new medications. So this is again important for a particular differentiating factor which I'll tell you. And then also you see the tongue is especially involved, and very, very important is that there is no urticaria. This is another important kind of indicator. And then the giveaway in all of this is that low C1 inhibitor levels. So sometimes what you can do in your questions is you just go to the last part of the question and then just read. A lot of times, especially in your INI CET, not so much maybe in your INI SS or NEET SS, the stem is made so long just to confuse you or make it seem like a very big question and make it kind of seem it daunting. But what you have to focus upon is the last few lines, and then you can go back to read the whole question. That is one of the tricks I used to apply. So here if you read that a low C1 inhibitor levels is seen, which of the following is most likely diagnosis, you can directly mark it as type 1 hereditary angioedema. So here you basically see a very important table which has been asked in many of your quizzes, and it is a very common question asked in vivas. At least in my particular college it was asked multiple times. So the angioedema difference is seen with respect to histamine or mast cell or bradykinin mediated. So whenever there is histamine, for example, as we saw here, the insect bites, new medications, trauma, etc. are there, then you will see very prominence of urticaria that is there or itching that is there, while in bradykinin mediated, for example in hereditary angioedema, there is no itching or urticaria that is there. Then the GI involvement, GI in the sense your oral tract, be it your tongue itself or your larynx, oropharynx, all of this, and along with abdominal and genital, all of this are more seen in bradykinin mediated or hereditary angioedema. While if you look at earlobe involvement or ear involvement in general, that will be seen in histamine mediated or mast cell mediated angioedema. So this is a very important table that you have to remember. Has been asked in multiple times in our vivas and quizzes, not really asked in your SS entrances, but it's a very important to be remembered for your clinical skills as well. Then you have this question which has been asked in your INSS once, that is the difference between various type of hereditary angioedema. You can easily remember, usually the depths of it is not asked. Main difference that you have to remember is that the levels of CINH is low in type 1. So here it is a more of a quantitative defect, while here it is more of a qualitative defect. And both of all three are genetic defects, but what you have to remember in type 3 is that it is neither quantitative with respect to the C1 esterase inhibitor, is neither quantitative nor qualitative, but it involves other factors, right? So these are the various three types of hereditary angioedema. So here this particular patient's clinical presentation of recurrent sudden onset swelling with lip, tongue and upper GI involvement with absence of urticaria or a trigger, along with the giveaway of low C1 esterase inhibitor levels, highly suggestive of type 1 HAE. And here there is a deficiency of functional C1 inhibitor protein. So doesn't mean the functionality only is defective, there is a defective in quantity of the functional C1 inhibitor protein, leading to uncontrolled activation of complement and other systems, leading to excess production of bradykinin, which eventually leads to this subcutaneous swelling, which is non-pruritic and non-pitting. often involves the various skin and mucosal tissues, can even involve the genital areas. Type 2, we have already seen dysfunctional C1 inhibitor levels are seen. The quantity is normal or sometimes even elevated to compensate. And here the main difference apart from this is that the prevalence of type 2 is lesser when compared to type 1. Then when we see the third option, that is histamine mediated angioedema, main thing that we have already seen is that there is no trigger, that is a small subtle clue, and very importantly there is no urticaria, hence you can rule out histamine mediated angioedema. Then ACE inhibitor angioedema you can also obviously rule out because clearly there is no medication intake history. Also there is a low C1 esterase inhibitor levels, because with that itself indicates that it's a primary deficiency and not a acquired cause related to medicine. So now we come to pediatric vasculitis question. So this is a very simple question but a very important question. I hope nobody has done ticked answer as C here. So cutaneous polyarthritis, I know you might not have heard it as written as this, but it is basically a polyarthritis nodosa variant, which is a medium vessel vasculitis. So this is the pediatric classification of vasculitis, where there is a large vessel vasculitis where it is Takayasu, then medium vessel vasculitis where there is childhood pan, and also there is cutaneous polyarthritis, which is basically earlier said as C pan or cutaneous pan, now especially in children called as cutaneous polyarthritis. Then there is our main disease, that is Kawasaki disease, and then various small vessel vasculitis and various variable vessel vasculitis are there. Among small vessel, you mainly have to kind of divide them, treat them into two, that is granulomatous and non-granulomatous. If you remember your days of reading Robbins, there are mainly three small vessel vasculitis which you used to read, that is microscopic polyangiitis, and in previously what was called as granulomatosis with polyangiitis, now previously called as Wegener's, and the third one is Churg-Strauss syndrome or EGPA. So among that, the kind of latter two, that is GPA or Wegener's, has granulomatous in the name itself, and that is in granulomatous. And then you have the third one, that is Churg-Strauss syndrome, also now called as EGPA or eosinophilic granulomatosis with polyangiitis, that also is under granulomatous small vessel vasculitis. Then you have non-granulomatous, where the third one, that is microscopic polyangiitis, comes. Along with that, there are various immune complex mediated small vessel vasculitis like inoxagonal purpura, HUV or hypocomplementemic urticarial vasculitis, and isolated cutaneous leukocytic. You don't need to leukocytic vasculitis, which you don't need to read in detail. Mainly what you have to remember is that these two are granulomatous vasculitis. Then these are again vasculitis which you might not need to know. Main two which you need to know are Behçet disease and Cogan syndrome. So Behçet disease and both of these are variable vessel vasculitis. Cogan syndrome is basically a aortitis that is there, along with involvement of eye and ear. So here again we won't go in detail into each of these vasculitis. Wegener's mainly involves your upper respiratory tract, lower respiratory tract and kidney. Churg-Strauss mainly involves your upper respiratory tract in the form of asthma. It can involve your skin, it can involve your renal tissue, and even your nerves and heart are common manifestations of EGPA or Churg-Strauss syndrome. Then you have cutaneous polyarthritis, that is mainly a form of cutaneous variant of PAN, which is mainly seen in palpable purpura, livedo reticularis, ulcers, nodules, gangrenes, etc. And it is non-granulomatous. Then you have HSP or IgA vasculitis, which is a systemic vasculitis of the body, and it is a small vessel vasculitis which is non-granulomatous, and hence that is the correct option here.